Thank you. Thank you, Angela, and thank you for the opportunity to present the final data from DolPHIN 1, which I do on behalf of the DolPHIN investigators, and this is our disclosure. So as you know, many women with HIV infection become pregnant every year, and in low and middle income countries, a significant proportion of these women will present late, will initiate antiretroviral therapy late in pregnancy in the third trimester. And that is a particularly high-risk scenario, which is associated with a 7-fold increased risk of transmission and a doubling of infant mortality in the first year of life. So our hypothesis was that the faster viral load declines that you see with dolutegravir may confer an advantage, firstly, in reducing the viral load at the time of delivery, and secondly, in the early period of breastfeeding in mothers who are still viremic. So the DolPHIN 1 study is a pilot study, a randomized controlled trial of standard of care, efavirenz-based therapy with XTC and tenofovir, or else dolutegravir with the same two nucleoside backbones. The study recruited mothers initiating heart in the third trimester, by which we mean 28 to 36 weeks of gestation, and dolutegravir was carried on for 2 weeks postpartum. To comply with national guidelines, antiretroviral therapy was started on the day of testing. So this was before eligibility and screening criteria came back. So they all started efavirenz-based regimen. And the mothers randomized to dolutegravir were switched to dolutegravir between 1 and 7 days later. The primary endpoint was PK. So we looked at the PK at steady state after 2 weeks of dolutegravir in the third trimester and again postpartum. We were interested in the in utero exposure of dolutegravir, so we measured paired cord and maternal blood. We were interested in the exposure of dolutegravir through breastfeeding, so we measured paired maternal breast milk, plasma and breast milk, and infant dolutegravir concentrations. And we were interested in the washout of dolutegravir following discontinuation, so we measured serial on serial days 1 and 2 and 3 exposure in mothers, plasma, breast milk, and in infants. Secondary endpoints were viral load in both arms and safety and tolerability of dolutegravir. So we screened 80 patients across the 2 sites, Uganda and South Africa, and 60 mothers were randomized, 29 to dolutegravir and 31 to efavirenz. 3 mothers discontinued treatment, allocated treatment during follow-up, 1 in each group for non-adherence, and an extra 1 in dolutegravir due to a raised ALT, which met liver stopping criteria. So these mothers were, however, included in our ITT missing equals failure analysis, as well as in the observed analysis. So there were no differences at baseline between the dolutegravir and efavirenz arms. So median age of 26 years, a gestation of 31 weeks, baseline viral load of 4 log, CD4 of around 400 cells. And the interesting thing to note was that a significant proportion of mothers were using herbals in traditional medicine. And in Uganda, this included a clay-based traditional medicine containing aluminium, and so mothers were asked to stop this treatment. So what were our results? So firstly, maternal exposure. So we did rich sampling in the third trimester and postpartum, and it should be pointed out that postpartum, which was intended to be 14 days, was actually a lot earlier, so 2 to 18 days with a median of 8 days. So this does not reflect a return to normal physiology, as you've seen from the earlier talks, and so not surprisingly, they weren't very different from third trimester. Third trimester exposures were somewhat low. So if you look at the trough in a non-pregnant adult, you would expect a trough of around 1,000 nanograms. This was 642. So what does that mean? There are 2 cited targets. One is a protein-adjusted IC90 of 64 nanograms per mil. So this is an in vitro target. And the second target is an in vivo target of 324 nanograms per mil, which comes from a phase 2A study of dose-ranging study of 10-day monotherapy with dolutegravir. So if you look at those two targets, all but one of the mothers had a dolutegravir above the protein-adjusted IC90. And I'll talk a little bit more about that mother later on. But if you look at the clinical cutoff, the MEC, the minimum effective concentration, 9 out of 28, so that's a third of mothers, had levels that were either at that level or below that level, okay? However, exposure, in utero exposure was significant, and this is consistent with previous studies, and the ratio is 1.21. In other words, the baby sees 121% of what the mother gets. What about exposure during pregnancy? So this is the same maternal exposure, but this time on a log scale to show the breast milk. And these are breast milk concentrations which are measurable at 3% of maternal levels. So we took breast milk sampling at around maternal peak and maternal trough, okay, and it's 3%. Infant exposures were somewhat higher. So the way that we did this was, because the baby is constantly feeding throughout the dose interval, peaks and troughs are probably not terribly meaningful. So what we did was we collected the infant plasma at the maternal trough, and then at the maternal peak, we mandated a feed, and then 1 hour later, we bled the infant. So we tried to use that to estimate the upper and the lower bounds of exposure in the infants. And you can see these figures, which roughly equate to about 5 to 12% of maternal exposure. So somewhat higher than the breast milk. And potentially in the range, here's the protein-adjusted IC90. So potentially, at least, giving the possibility of some added protection at high-risk breastfeeding. What happens if you stop treatment? So again, maternal levels here. And these are breast milk levels. So 24 is 24 hours after the last dose, i.e. when the next dose is due. 48 is after 1 day of missed dosing, 2 days and 3 days and so forth. And you can see in the breast milk scenario, there's rapid elimination of dolutegravir from breast milk, okay? So the limit of detection for the assay is 10 nanograms per mil. And after 1 day, only 1 sample is detectable and then none thereafter. Infant plasma is a different story. So the washout from infants is much slower following discontinuation, so that even after 72 hours, levels are still around the protein-adjusted IC50, probably due to decreased glucuronidation and reduced elimination. This is the interesting one. What happens to viral loads at the postpartum visit? And you can see that both by intention to treat and by the observed therapy, there was significantly greater proportion of women who were undetectable at around the time of delivery. So 69% in dolutegravir versus 39% in efavirenz, and this was significant. The panel on the left shows the Kaplan-Meier survival analysis of proportion remaining detectable, and you can see that there's a big difference between the dolutegravir in red and the efavirenz in blue, and the median time to undetectable was approximately half in dolutegravir compared to efavirenz. Back to the mother who had so one mother had completely undetectable dolutegravir concentrations and was not taking drug with no viral load response. Another with the dolutegravir level below 64 nanograms did experience virological rebound, but interestingly, the baseline resistance test showed high-level NRTI resistance, some NNRTI resistance, and quite surprisingly, quite a lot of PI resistance. This is despite no prior history of antiretroviral therapy. Safety. So first of all, the maternal outcomes. So it was well tolerated, and there were 3 serious adverse events noted, 2 in the dolutegravir arm and 1 in the efavirenz arm. The dolutegravir arm, there was a severe anemia, not related, and then the mother with the raised ALT after several weeks of dolutegravir. Interestingly, there was a just before the raised ALT, the mother did admit to taking some traditional medicines. There was a febrile illness, and then subsequently she had a stillbirth, which was thought not to be related to drug. And we'll talk about that in the next slide. In the efavirenz arm, there was a case of hypertension and preeclampsia, thought not to be related to drug. If you look at the infant outcome, the majority of infants were healthy babies, 57 out of 60. There was one stillbirth, which I mentioned before. This is thought not to be related to dolutegravir, and the cord was tightly wound around the neck. There were two congenital malformations, both in the efavirenz arm. One was a polydactyly. The second was multiple skeletal and limb defects, as well as cardiac defects, and thought to be syndromic. And there were three serious adverse events in the babies, the third one being neonatal sepsis, again thought not to be related. So, what are the conclusions? So in this pilot study, which is small, a significantly greater proportion of mothers initiating heart late in pregnancy achieved undetectable viral load in the dolutegravir arm compared to the efavirenz arm. This is despite dolutegravir exposures in the third trimester being relatively low. This is comparable to the PANA cohort, but slightly lower than the impact investigators reported. But in utero, accumulation of dolutegravir was high, again in the range of previously reported levels. Breast milk accumulation was 3%, but in breastfed infants, this was higher, around 5 to 12%, likely related to decreased elimination and reduced glucuronidation. And as I said, this offers the potential for some added protection in high-risk breastfeeding. Upon cessation, dolutegravir is rapidly eliminated from breast milk. However, infant washout was prolonged. I should say that there were no reported cases of HIV transmission in this cohort. Safety of dolutegravir and efavirenz was comparable, but it is a small cohort, and evaluation is limited by sample size, the relatively short period of follow-up, and also by the prior use of efavirenz in all dolutegravir mothers. We have a definitive trial, DolPHIN 2, which is a randomized comparison of dolutegravir versus efavirenz, this time throughout all of the third trimester, so 28 weeks to labor, 250 women in all, with continuation of dolutegravir throughout breastfeeding until weaning, and 72 weeks postpartum. And I'll finish by thanking, first of all and foremost, all the mothers and the families who participated in DolPHIN. This was not an easy study to do, and also all the DolPHIN investigators. And we acknowledge support from ViiV for project funding and drug donation. Thank you very much.